Okay, sure. My webcam's dodge. I'm sorry, but anyway. Um, hey, well, welcome to the podcast. With us, we've got our regular host, Hustling Ninja. It's been 6 months, and today we're coming back with I think, a very interesting guest. Um, we've got Dr. Hash Abdeen, who is with us this evening. Do you want to say hi, Hash? We're both Hash, but anyway.
Yes, we can be like hash 1 and hash 2, like B1, B2, whatever you prefer, other hash.
Yeah.
But nice to meet you both as well from medical school. But for those who haven't met, my name is Hash Abdeen. I am a rheumatologist. I work and live on Yugambeh lands in the Gold Coast, but I'm also now a newly minted medical admin trainee at the Royal Brisbane and Women's Hospital in Queensland.
Awesome. So we had an episode earlier in the year about BPT. So I don't really want to get into BPT. So we're gonna, this podcast we're going to talk about your career and why you've chosen to do things and how you got into those certain fields. So I'm going to skip through BPT, and my personal interest is your medical admin role, but I will ask by starting about how you got into rheumatology, why you chose rheumatology, and what it's like being a rheumatologist.
Interesting. Yes, BPT is probably boring for most people because lots of people are basic trainees now or have doubled in it. I had a very linear path, but I did, my internship in JHO year or PGY2 year, as we call it here in Queensland, and then just got straight into basic training. Had a very linear pathway in terms of, doing my physician exams, and then had to make a difficult choice about what to choose in internal medicine. And I guess I chose rheumatology for several reasons, like everyone does, and I'm sure you have your own experiences and reasons why you chose your different specialties. But of course, I like the science behind it, the new medications we get to use. But ultimately, I think I like the chronic care patient and really being able to sit down with my patients, see them every 3 months for the rest of their lives, and get to know them and really be able to change their lives completely. I think pain is one of those very visceral symptoms that affects your entire life, everything you do. I mean, I get a paper cut and I can't survive the day. But if you can't move your hands, or you can't, get change in the morning because of how much pain you're in, it's really nice to be able to help someone with that, pain. I also think the other reason is around these patients haven't done anything wrong. They've really just been dealt the bad genetic card. They haven't drank too much or smoked too much or eaten too much. Really, they're just waken up one day with this horrible immune disease. And usually they're young. They're in their 20s, 30s, 40s when they get these diseases, and really, really changes their entire life and outlook on life. And so be able to help these patients, they're usually very grateful patients because of the way that you can help them with. So it was definitely one of the reasons, or one of the main reasons I got in. And also because I think rheumatologists are a good fun bunch.
Do you mostly see, what age group do you mostly see in rheumatology? I imagine there's like a pediatric rheumatologist, and then there's, what do you see?
Yeah, so we usually see anyone from 16 up to, end of life, really. Pediatric rheumatologists will see everybody below that, and so we're not really scoped for or have a scope of practice for anyone who's below 16 years of age. Interestingly enough, where I work on the Gold Coast, we've started a transition clinic because we realise that it is a gap, particularly when you have had this terrible disease where you've built this bond with somebody for the last 10 years, ever since the age of being 6 or 7, and suddenly you have to go from that to the adult clinic, which is often much more independent. You don't have as much support. A lot of the pediatric clinics have nurse navigators, for example. And so we've realized that a transition clinic is really important to hand over that care, and particularly how rheumatology diseases evolve from pediatric diseases to more adult diseases. That's also a good transition to kind of hand over and investigate further and manage differently, because we do have more access to biologics, which are one of the main drugs we use in the rheumatology world.
And is it true there's no such thing as a full-time rheumatologist?
Yes, I guess maybe one of the other reasons I chose rheumatology. There are some. I think they would probably be not in our generation or even probably the generation above us, but yes, there are still some full-time rheumatologists, but most of us will work smaller FTEs. And I think that's with most specialties these days. Most people are doing a balance of public, private, and then other. And I think that's a lifestyle choice probably because us as junior doctors these days don't really want to be working, more than 5 days a week or 6 days a week or 7 days a week as our predecessors used to. A lot of us are happy with 3 or 4 days. And, the pay that comes with that, we're pretty lucky to be able to be paid well, regardless if you work full time or not.
Amen. Definitely.
By the way, can I just before we move on to the other side of it, do you want to just tell us a little bit more? Obviously after BPT training, so you set the basic exam, pass it. How do you get into rheumatology, and what's the pathway to that?
Yeah, so once you finish your basic physician training exams, which happen in your third year of basic training, or that's the earliest you can sit it, you can definitely choose to sit it whenever you decide to. And there is a maximum that the college allows you in terms of attempts wise to sit those exams, but also duration wise in terms of years. But then you get to choose your advanced training specialty. So the RACP, which is the Royal Australasian College of Physicians, is our college that does allow you to choose up to 38 adult medicine specialties, which anything from cardiology to respiratory to rheumatology. And so then you would apply within your jurisdiction, your state or territory, basically, to the rheumatology pathway within your state or territory, which was, of course, my one in Queensland. And then you go through an interview process to get on. Rheumatology is one of the smaller specialties, and so it is quite competitive. In the year that I got on, there was 3 in the whole of Queensland, so I was quite lucky to get on my first attempt. But most people will get on within their first or second attempt for most of the subspecialties within internal medicine. Some of the ones that are probably more challenging are cardiology, gastroenterology. But again, most people will get on within their first or second attempts to get onto the programs, which is quite good compared to some of the surgical specialties, of course. Yeah.
But then what happens to people who don't get on? What do they do for...
So there are a couple of unaccredited registrar jobs, just like there are in other specialties. So rheumatology has a couple in Queensland, and there are a couple in other states. Some other people may decide to do a general medicine pathway, and I think a lot of people now are dual training with general medicine, which I think is quite a good thing. I didn't actually do that, and I probably regret maybe not having some of the general skills, because you do de-skill in general medicine, even though as a basic physician trainee, you are general medicine, you'll peak your knowledge after your exams. It slowly becomes very subspecialized towards, rheumatology or whatever specialty you're in or subspecialty you're in. So I think that is becoming a very popular option in terms of dual training, particularly with rheumatology, but a lot of other specialties as well, including things like endocrine, general medicine, geriatrics, sorry.
But you are dual training.
Yes,
just not in Gen Med advanced training. He is dual training.
2 college fees. It's out of control, don't worry.
Yes, exactly. And the opera fee just went up, and oh my
God.
Yes,
we can talk about that later on when we're talking to some of my roles.
Yeah. Exactly. So I briefly stalked you.
Oh, good. Okay.
And you've as you do, and you've done a lot of. You've had a lot of leadership roles and a lot of advocacy roles, and I assume that is then what leads you into dual training in medical admin. Tell us, when did you first take on a leadership role and why within the medical sphere? That is,
I was just going to say,
maybe you did something musical in school or something.
I was just going to say I was school captain in 2007.
I knew it.
And I think I'd seen me through medical school doing all these leadership roles as well. So I ended up being, the MedSoc president for our university back in the day. So it was kind of inherent, I think. And people have this debate around, whether leadership skills are inherent or, can they be learned? And I think they're a combination probably. And some personalities, of course, are, more leadership prone. But you're completely right, Hash. 2. I'll call you Hash 2. I don't know what you want to be called, Hash.
Yeah, that's good. I'm happy with that.
But I guess it was medical admin was kind of formalizing the leadership roles that I've had. In a couple of different spaces, in the leadership world. And I think you just learn on the fly. None of us are really trained in how to run a meeting or chair a meeting and how agendas and meeting minutes work and meeting etiquette and when to put your hand up and not, and to be diplomatic, which I think is one of the biggest skills that I've learned over the years. So through my junior doctor years, I did some intern roles. I ended up chairing a national group called the Australasian Junior Medical Officers Committee, or AJMOC for short, which sits under what is the accreditation bodies of all the different states for internship. And so that was really interesting, and that was my lead into the AMA. And so I did a lot of roles within the Australian Medical Association and ended up chairing both the Queensland group and then the Federal AMA Council of Doctors in Training, which is a fantastic group. And there's a lot of advocacy work, and there's a lot of passionate junior doctors out there. I encourage people to get involved if they would like to, because you do get to make change. And I think that was what attracted me to these roles where, I think both of us and all of us probably listening to this podcast today know that there's areas and issues within the healthcare system, the way that we train, the way that we go through medical school, the pressures that we put under as junior doctors, but also the pressures our patients face, it can be really challenging. And unless you have an outlet for that in a positive way, I found that, being able to be in a position of power or leadership that can change and actually make change was really, really important for me. And was, I think, important for me when I thought about my careers. And I think that's why medical admin attracted me to that kind of training pathway.
God, there's so many different points you've made that I want to...
Sorry, yes?
There's so many... Sorry, it glitched, sorry. There's so many points that you've brought up that I want to unpack, but I also think that would take like a long, long time. So you're very right in saying, because, in med school, you're told that doctors are leaders and leaders within the community, but you never actually taught how to be a leader or how to lead. And so you're very right in saying, maybe some of it's inherent, but some of it you actually have to develop and commit to developing. Hence, I guess, the training pathway that exists in medical admin as well. So there are issues within medicine, and we can touch on those later. But applying to medical admin roles, the medical admin training program, from my understanding, you have to find or create the job and then it gets retrospectively accredited in the college. Like, how does the application work? I feel like I heard that somewhere. I don't know if that's true or not.
So it's different, again, in every state and territory. So you're right. There is multiple pathways into the Royal Australasian College of Medical Administrators, or RACMA, which is medical admin training. You can go into what's called a registrar position, of course, like any other registrar position, and you can only do that after doing 3 years of clinical. So you have to do a minimum intern year, PGY2, and a PGY3 year in something directly clinical, and then you can apply to the college to enter into registrar positions. Every state is slightly different in terms of how many actual registrar positions there are, and these are, accredited positions that are, looked at the college as being, a broad experience in the curriculum for medical administration. But as you mentioned, Hash, there are other ways of getting into the college, and you might be in a substantive role already. And what I mean by substantive role is if you're already a director of clinical training, or if you're a head of a department, or you're already a director of medical services or a CMO, but you haven't done the full medical admin program, you can ask the college to accredit that position. Likewise, if there is a special interest that you have, so states like New South Wales and Victoria might have a special interest within the Department of Health or the Medical Council of New South Wales, those positions are unique and quite a specific position, so you need to take that in mind if you consider doing those positions. But there are positions that have been created and then being subsequently accredited for RACMA training. They're probably not positions where you'll get a breadth of experience, because you'll, of course, get a very specific experience, but it is a nice entryway into the college if you are struggling to get a registrar position. Traditionally, in terms of, success rates of getting the program, it has been pretty good, but it's a very popular specialty now, or growing in popularity, because of, number one, there's just more RACMAs around, or medical administrators around. But number two, I think it goes to the point around what we talked about earlier, which is around flexibility in your career, and having non-directly clinical days is quite actually interesting and quite balancing for most people. And I do find a lot of people in medicine who aren't burnt out, who are still happy, are the ones who've got them something medicine adjacent that's not direct clinical care, whether that be research, education and training, something that, is slightly different and provides them variety in their career and their day-to-day job. And I think that's what medical admin does for a lot of people, actually.
And do you need, because obviously you've had many prior leadership roles, is that what RACMA, is that what the college is looking for in their applicants, or what are they looking for?
I think they are looking for leadership qualities. I think as a medical administrator, and you probably know this as clinicians, you want a clinician who's, got some leadership qualities to be able to lead, I guess, the medical workforce within whatever situation you're in, whether it's, in a primary care situation or a tertiary massive quaternary hospital pathway. So they do look at those things in terms of leadership. The question styles are very much, tell us about you and your qualities and skills that sets you might have. And that's some of the interview questions, but also around how you manage particular situations. Say, for example, you're having an issue regarding one department and another department and how you would resolve that. And so they want to see things around communication skills and really how you can, I guess, build the networks that you need and the true connections you need with various departments to be able to resolve sometimes often tricky issues. They're also very concerned around performance management, which is obviously a big issue for doctors, particularly when things go wrong, whether that be from a performance management issue, so a surgeon who's got higher complication rates than the rest of the department, or whether it be a behavioural or a health impairment issue. And so those can be really tricky conversations, right, to have with somebody to tell them, well, actually, we need to take you off the floor and, we need to report you to the medical board or APRA. And that can be really tricky. And so having those real connection or skills of communication and be able to, I guess, have difficult conversations is something that they want to demonstrate. Now, of course, we know if you're PGY3, you may not have the developed skills yet to do that. And so, this is an entryway pathway. They're not expecting you to be a fully formed medical administrator at the start of your career. But it is useful if you've had some leadership experiences. The other thing that I think is interesting is, whether you should have another clinical specialty before medical administration. And I think there's pros and cons to both sides. I mean, I finished my rheumatology before I started medical admin training, and I think it's given me a lot of great skills to be a rheumatologist. But as you mentioned, Hash, before, I don't think it's taught me necessarily how to be a rheumatologist within the system and how to navigate the system and how to help my patient navigate the system. And I think that's what medical administration really helps you do to become a leader within your own specialty, but amongst the specialties as well.
What does your week look like? Are you doing like 2 days clinical, 2 days non-clinical? Like, what's your week look like?
So at the moment, it's a bit crazy. I'm doing 4 days of medical admin training, mainly because I want to get through the training program. As anyone is on a training program or about to get on a training program or is a trainee doctor, the hours can be long and they can be tiring and difficult with all the training requirements that you have. Medical admin training is actually one of those specialties that the training pathway is relatively protected. You are protected as a registrar, but as a CMO or DMS or a health leader, you're much less protected than a general consultant, I would say. And we can get to that topic around, how we look after our leaders as well, because that is a really interesting topic in itself. But yeah, so my day-to-day, and then I do 1 day clinical. So I do 2 to 3 clinics of rheumatology publicly on the Gold Coast. But my day-to-day in medical administration is everything from multiple meetings around, things that have gone wrong, to, things like project work, policies and procedures, credentialing, which is ensuring people have the right, skill set to be able to practice in that specialty within their particular facility. Things like governance issues, clinical governance, clinical incident management. So when something goes wrong in the hospital with the patient, we help the clinician and also the whole team around patient safety and quality of care type measures. So there's a lot of things that go on. Like I said, I think I alluded to before, performance management is probably the thing that I'm struggling with the most because it is challenging, because I do feel that most doctors, I think, come to work thinking they're going to do a good job that day. Like, no one is trying to be a bad doctor, I don't think. But things go wrong, and we know things go wrong in hospitals, and it's really difficult having those conversations with somebody who really probably cares a lot about the patients and the care that they give, but things are not going so right. And so I think that is probably one of the more challenging aspects of medical administration that people need to be prepared for. The other thing that I think, just to mention, and mainly because I think some people think potentially that medical administration is quote unquote easier or less stressful, there are actually longer hours than you might
God,
think.
sounds terribly stressful.
Yes,
Having a conversation like that sounds terribly
it
stressful.
is, right? And when things go wrong, everyone looks to you as the DMS of the hospital. And there is on call, and there's a lot of on call, and it's lots of on call. There's lots of calls that come, and they're not really simple calls that will come through about something clinical. It's about really complex things that have gone wrong with the hospital, and you are now in charge of sorting it out for the entire hospital, which impacts thousands and thousands of lives, if not millions, depending on how big your health service is, right? And the catchment. So I think the gravitas of that is quite big, I think. And I think the responsibility that you hold is almost higher than any other doctor within the hospital, because anything that goes wrong, really, people look for you to manage the situation. And also the reason why it happened in the first place could be your fault, really, when it really wasn't you who was involved. And so it's really interesting how that all plays out, and how the medical leader's role is, can be quite a stressful role given the responsibilities that you hold.
I've never thought about it like that, but when you put it into that perspective, I would much rather be on call for a clinical specialty than that, to be honest. I thought RACMA registrar on call was like, oh, we're understaffed in the ED, activate the standby on call.
Yeah,
that's what I thought it was, but clearly not.
I wish it was. I mean, I feel like I've had some interesting calls around, not that I will disclose lots of things, but just things that are just out there, right? Things that you're like, someone's been stabbed in the middle of the main atrium, and that was an interesting call that I got recently. And then how do you manage that? There's police involved, there's bystanders involved, there's everyone. It's just, and you have to make sure, things are done correctly. And there's no, handbook for this, right? There's no curriculum for that, really, but it's about how you manage from a risk-based approach to manage that situation and make sure the patient's safe, the staff are safe, and bystanders are safe as well. And so, those type of things are really important. And COVID obviously was, one of those really, really challenging times where we saw medical administrators be really stressed out, because suddenly they have to manage everything that the system is stretched already to become, super stretched. And that's what, was quite stressful for some of the medical leaders at that time, I think.
I feel like there's potentially a pessimism that doctors have around admin and medical admin. I don't know if you would agree or disagree, but I think there is a general pessimism around it. Why do you think that is, and how does that not get you down?
Yeah, I think I'm in a unique situation because I'm practicing as a clinician still, and so there is that interesting kind of duality that I have in my role. Often people will say, oh, you've gone to the dark side, and you're right. I think people think it is the dark side to some extent.
Yeah, I think I've heard that, yeah.
I think it's just, it's about realizing that as doctors, we're not very good at representing ourselves. We're very siloed in our specialties. We define each other by our specialties. And, that compared to our other colleagues like nursing and allied health, who are very collegiate and really promote each other, and therefore they're in leadership roles all the time. The health service that I'm in at the moment, the CEO and the COO is a nurse, multiple executive are nursing staff, but there's one doctor on the executive. And so, and I think that's because we don't really value, I guess, the role that doctors could play in those positions because of our training and the way we, can clinically reason. We do have a broad, mindset when we're approaching a patient. And so I think the same skill sets that I use in rheumatology with this, diagnostic problem is often what I'll use in medical administration. And it's funny because I can apply my medical knowledge almost and clinical reasoning pathways to that. And I think, often doctors are quite smart people, so we would make good leaders in these positions, and we do understand the health system, and we are able to make changes. And doctors do have a lot of power within the health hierarchy, really, and so using that power for good is kind of what I'm promoting, I guess, through all of this. But you're right. I think it can be challenging for people to understand the real role of a medical administrator until things go wrong. And when things go wrong with your patient, or if you think something's going wrong in your practice, the best thing is having somebody who has the skill sets to be able to help you manage that. And I think that's the ultimate role of a medical administrator, is to help our staff, our medical staff, when things are going not so right, whether that be both professionally and personally. And you are able to go to your DMS or your CMO or whatever you call it within your state with any issue that you may have, whether it be patient related or not, and we're able to help navigate that for you and work with you to come up with a solution. And I think if we can sell it that way, I think it becomes much more valuable by your colleagues, because you realize you've got somebody who's advocating for you, who's supporting you, and really, therefore, to represent the medical voice.
Are you still a chair in the AMA for the Council of Doctors in Training, or is that old for me? I don't know.
No, I finished.
Is that ongoing?
I finished that role probably about 2 years now. I did it during COVID, actually.
I'm not good at stalking.
Yeah, no, it's fine. It was a good role, and I think, as I mentioned earlier before, the AMA is an organisation, that does a lot of advocacy and promotes the leadership within the juniors. And it was a good role to be able to advocate on a federal level, and you get access to all the federal stakeholders, including the medical board, the AMC, all the colleges. I frequently was talking to college presidents and college CEOs, the Chief Medical Officer of Australia. You're talking to health ministers. It's a really great role to be able to just talk to people who have the powers and the levers of change, right? I mean, you don't every day get to know all the presidents of all 16 colleges or CEOs, or, talk to the health minister about things, So these are the type of roles that I think actually can make change. But happy to talk about the medical board and AMC as well at some point.
Yeah, I was just going to quickly ask, when you were in that role, what was the biggest concern or interest, I guess, and what were the topics that revolve around that you guys were discussing then? And also, do you know anything about what has changed now as well? And what are they actually discussing?
Yeah, so I think the biggest things that we were talking about, at least from a doctor in training or junior doctor perspective, was, well-being, staff burnout, bullying and harassment, and then obviously the impacts of COVID at that time on education and training for trainees across the country. So there've been lots of advocacy around that. I mean, then I remember I think it was March 2020 that I took over, and I remember my first phone call was to the Medical Board of Australia chair around the internship requirement, and realizing that people were going to be having to take lots of leave during COVID, and they might not make their internship requirements to change. And so that was one big thing that we worked on, and we were able to, reduce the requirements at that point temporarily just during COVID years. There was lots of, as you may or may not know, there were lots of examination failures for various colleges because they've moved to online quite quickly, and that had lots of implications for trainees' lives. We know trainees often study a whole year for their exams, and if your exam is cancelled because of an exam failure or technical failure, it's quite distressing. And so there was a lot of advocacy around that, and having contingency plans, which a lot of colleges did employ afterwards, which is really good. The other thing that we've been working on and had been working on for many years before that and had led up to that is what's called the Medical Training Survey, which some of you will know from the Medical Board, as you do that every year with your registration for junior doctors. So there was lots of discussions around how to capture the right data for that. And so we had a lot of feedback into that survey and how it's been going and ongoing as well. Things that have come out from that is flexible training pathways. And so we really have pushed lots of colleges now to flexibly train, because we know the workforce is different. We mentioned at the start of this conversation, people are not wanting to work full time. And that's not only specialists when you get your fellow ticket, but that's junior doctors as well. Some junior doctors want to work, 6 or whatever it is, or 2 days a week, or whatever they want to do. And that's probably because we're graduating at older ages. A lot of us have kids now, a lot of us have mortgages, we've got other lives and we've got other careers as well. And so some people want a flexible training pathway, and we should allow people to do that within, what's reasonable, of course. And so I think, there's lots of good things that have come out from those areas and those ages. And have helped things like gender equity and moving things around like parental leave for colleges rather than just maternity leave and how we afford that. So there's lots of good advocacy that's come out of those years, I think, which I'm proud of. But I think, the everyday trainee, I guess, probably doesn't realize that there's so much going on in this space to make things better. And there's still a long way to go, but I think things are getting there.
Okay. Why do you think this, such a small percentage of junior doctors joining the AMA? What would you tell a junior doctor to get them to join? What's the not the sales pitch, but how can we get more junior doctors and doctors in general to join the AMA? Because I feel like it's, compared to the nursing union, it's so much smaller subscription rate.
Yeah, and I think it is a challenging thing for doctors, and I think it's because I kind of mentioned this before about how we're so siloed. So you could be part of your college, you can be part of the AMA, you can be part of the Doctors for the Environment, you can be part of multiple other groups that you could be spending your hard-earned money on. And we know junior doctors are living in a pressured world in terms of cost of living, and so you're going to put your money to things that are going to reward you and go back to what you do. And I think that's a message for the AMA more than to junior doctors out there, in that really the AMA needs to be looking at how we better service members. What do junior doctors really want, and really understanding that and appreciating that. And then if you give something that's offering to them, then you will get membership just naturally flowing on. The difference between the nursing union and us is that the nursing union provide the indemnity. So how we have MD National and Avant and all these types of groups, the nursing union are the indemnity provider.
Yeah, yep.
So that's usually why they have almost 100% membership. The other difference is probably for us is that in some jurisdictions or states, your ASMOF or your union is separate to the AMA, and so that can be quite challenging, I think, for those states. But for states like Queensland, it's pretty a no-brainer. I mean, I think it's kind of like insurance, and you probably will see if any of you have tried to reach out to the AMA / your ASMOF or your union. Once you've had an issue, they usually won't be able to help you. But if you're a member at the time, then they'll be able to help you. And that's just like any insurance company, right? And so there are a lot of junior doctors who face lots of issues with industrial issues, with contracts and things like that. And that's, it's nice to have insurance to be able to help you once you do that. And I think particularly a lot of people who are moving into consultant world, if you're reviewing private contracts and other contracts and things like that, they're quite useful in that space as well. So there are benefits in that space as well, other than just, of course, joining a leadership organization and having some personal development from doing leadership roles.
All right. Let's move on to AMC. What is your role in the AMC?
So I have several roles with the Australian Medical Council, and mainly, I guess...
You're not busy enough.
I know. This is the hard part. And we haven't talked about the medical board yet, which I think is probably the most interesting role out of them all, but we'll talk about that afterwards. But with the Australian Medical Council...
Save the best for last.
The Australian Medical Council, for those of you who are not aware, is basically the accreditation body for medicine. So they accredit all the medical schools in Australia and help out the Medical Council of New Zealand in New Zealand. They accredit all the colleges, and they also accredit all what's called the pre-vocational medical councils. So in each state, there is an intern accreditation authority, and they accredit them as well. And so, of course, they have a lot of power, in a sense, through that accreditation lever to make really positive change. And that's really what I got involved with them for. So I sit on their council and sit on a couple of their committees, including what's called the Specialist Education Accreditation Committee, or SEAC, who accredit the colleges. So I'm probably more experienced in accrediting colleges. I just came back from Melbourne last week, where I spent the week accrediting the Royal Australian College of General Practitioners, which is a big college, obviously, RACGP. And so lots of things going on with that college, and lots of good things as well. And so there's, I guess, accreditation standards that we accredit the college to make sure that they're meeting the requirements. And that goes from anything like making sure you have a trainee voice within your college, that supervisors are getting the right training, that there is a good curriculum, that there is good assessment methods, that, colleges are communicating with their trainees in a timely way, particularly around things that affect us, like, fees, which, have been a problem for some colleges where the fees have gone up suddenly without trainee consultation. Changes to examinations, changes to entry criteria for selection into their training programs, all these big issues that affect trainees' lives. Really, colleges know they should be consulting with their trainee body beforehand, and where they need to, the pre-vocational space as well, because we know a lot of colleges and different pathways do have a large amount of unaccredited trainees and who are really vulnerable. And so making sure that that cohort is looked after well is also important. But at the moment is still, lacking in terms of that accreditation space. So it's a good role, and I think it's definitely something I encourage people to get involved with. You might be an accreditor as a junior doctor in the intern space, so we're always doing that. So in Queensland, we have lots of people who are on a panel who do and accredit the intern training positions, for example, within the various hospitals. You can do that in your physician college, so basic physician trainees, but there are other colleges as well that have trainees on their accreditation panels. So it's a great way of ensuring there is good quality education and training of whatever organisation or training side, but also areas for improvement. So it's a quality improvement tool as well. So it's, again, one of the reasons I got involved is probably because it is an actual way of making change, and which is really, really difficult as an individual trainee or fellow, really, within your college or whatever space you're in.
I feel like every little while I see something about universities developing training programs, and specialist training shouldn't have to just be through a particular college. Is that, I don't know, is that just like sensational media that I read, or is that a thing?
So it's definitely happened internationally, where universities have taken over some specialty training components in particular, but also at large whole training programs. And there is this kind of thought pattern around, I guess, colleges having a monopoly of training. So, you can only be a rheumatologist if you go through physician training. You can only be an ophthalmologist if you go through RANSCO. There's no other colleges, and so there's no market, right, in terms of consumers. However, I think it's a kind of a be careful what you wish for story. Anyone who's done a master's or any other higher degree knows that it costs tens of thousands of dollars, if not more, to do that through university. And so that's kind of the alternative. I think universities have fee structures that are much more interesting, I think, than colleges. And they are much broader organizations that are not really, medicine specific at all. And so there is that kind of caveat with, if we were to go down that pathway ever, would that dilute education and training, quality of education and training, and would it potentially increase our fees dramatically? Well, that is a huge risk. And I think potentially the grass is not always greener on the other side type situation. But it is definitely something that's been talked about, particularly in the medico-political space, because there is a lot of pressure on colleges now to make sure that they're performing and meeting community need, for example, which is one of the biggest things, of course, right? We're producing all these doctors, but are we producing them in the right way? Are we producing them in the right amount? Are they going to the right areas? Do they have the right skill sets? Are they generalists rather than super subspecialists? And what is a college's role in ensuring that when you're producing a product, because ultimately that's what you're doing, we're all somewhat products as junior doctors and as specialists, are we producing the right product, which is a specialist who can service the whole community, no matter where you're living in Australia?
Okay. The medical board, saving the best for last. I did touch on APRA fees going up. Did you do that, Hash? Did you do that to us? No, I'm joking.
I'm the culprit. It's me. I'm the problem. It's me. To quote Taylor Swift, it's me.
We got him.
I'll mention fees. We can
tell us your role in the medical board.
Oh, okay. I can tell you about my role. I was just going to tell you about fees.
Hard-hitting journalism.
Fees are interesting. I think, again, it's about this is very much my opinion. It's not evidence-based or anything like that, but it's kind of the same conversation we had around colleges before, around the grass is green on the other side. At the moment, as you probably know, the medical board is profession specific. So it's medical practitioners reviewing medical practitioners with community members involved. So for those of you who don't know the structures, APRA is the agency at the top that sits on top of all the national boards. There's 15 national boards. So medical board is one, there is a nursing board, there's a physiotherapy board, and etc. for the other professions as well that are registered. The medical board has a national board, and then we have state and territory boards, and I'm a practitioner member on the Queensland board at the moment. And so most of the boards have what we call parity, which is community members and practitioner members, and they make decisions based on what we call notifications, or the common language as a complaint. So, of course, a complaint can come from a patient, they can come from another practitioner, and they can come from your employer, depending on what's going on. And there are also notifications that come from, you having to personally provide a notification. Say if you have a criminal offence that you're convicted, you have to notify the board of your criminal conviction, and so that might be another way that a notification comes through. My whole point around this being profession led is that it could be through the legal system, and so we could be going to court. And you probably see in the US there's a lot of litigation against doctors for medical negligence. There isn't a huge amount of litigation in Australia. And I think one of the systems that supports that is, the medical board system, I guess, or the APRA system in terms of the national law that supports that. But it is more complex than that. Of course, the US system has different legal systems than we do, and I'm probably oversimplifying a bit. But I think it is nice to know that if you get a notification because a patient has been upset, that you will have medical practitioners who are quite informed and community members who are also highly selected people to come into the group and make a decision based on your care and whether you provided the best care possible. Or if you've got a health impairment, for some reason, whether you've got a mental health disorder or a physical disorder or whatnot, that you will have a compassionate group of people who are looking into your case. And I know it's not always looked at that way, and APRA and the medical board is probably seen as a organisation that's unfriendly and unkind. But I think it's really becoming more balanced in the way that I've seen decisions being made in terms of making sure that we take the least punitive approach, and it's not supposed to be punitive, at all. It's a non-punitive approach, really, to making sure that you're practicing safely. And if you look at it as a process of this group of people trying to support you to practice the best way you can and to continue practicing the best way you can, then that's what it is really when it comes down to it. But I do appreciate there's still a lot of stigma around getting a notification. There's a lot of stigma around being reported to the medical board, and not most people will have one at least throughout their career, if not more. But it doesn't necessarily mean you're performing at a low rate. I mean, most notifications that we get are probably only 3%, 3 to 5% really get any kind of conditions or suspension or anything like that. And so most people are doing the right thing, and we know people are doing the right thing as well. But it is an interesting role because people do look at you differently when you say you're on the medical board, I can tell you that.
That's what I was going to say. That's part of the pessimism that I think I've observed. And I don't know if you are part of any online groups or forums, whether it's Facebook groups or whatever. There was a lot of discussion about the APRA fee increase and why are we paying this fee and why did it go up? Is it just for them to look into complaints that aren't substantiated, blah, 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 blah. So there was a lot of pessimism around it. But when you talk, Hash, you're convincing me. You can increase my fee again if you want. I will pay it because you've sold it.
I mean, I didn't really go into the fee. I mean, I guess the fee part, and it is interesting because you're right.
I'm joking.
Well, I meant I guess a lot of us, there isn't lots of money involved. I mean, this is an organisation that gets no funding. So the medical board gets no government funding. It's self-funded. So the regulation is self-funded. And with that, there is a cost to regulation, of course. And if you are the person being investigated, you want to make sure that the right person is doing a thorough job of you and supporting you and the whole case, which takes a lot of time and effort, right? To make sure that the case is heard well. And like you said, most cases don't end up with anything, but it's hard to know that as an independent person or third party. You know, if a patient has come to you with a complaint, at the present time, under the national law, all complaints should be investigated. Of course, some are closed off very quickly. So, for example, during COVID, we had a COVID national committee that looked at things like, oh, I saw my doctor going to the movies without a mask on, for example. And so those things are, you know, low risk to the public in ongoing, you know, and we'd probably just say, well, they don't need any education. They know that. They probably just need to be told, okay, that's probably not good. And that's it, really. And we obviously have a natural justice process as well, and procedural fairness process, where the practitioner is given the opportunity to tell us, oh, actually, I just took it off because I was just sneezing or I was eating popcorn for that time, or whatever it is, right? And so, you know, those whole processes take time and money. Things are moving much quicker than they used to be. I mean, I've only been on the medical board for 2 years now, or just over 2 years, and there used to be a big delay for notifications, which you would have seen on the social media groups, is quite distressing for practitioners when you're just waiting in limbo for 3 months, 6 months, 12 months for a decision by the board about whether you can practice or not, or whether you get conditions or not, which can be quite scary. But the other thing to say around the fee increases is that, unfortunately, there are doctors who are doing bad things, and we do say that, like really bad things, and we see that with the new cosmetic surgery review that's gone on. There's a lot going on with medicinal cannabis at the moment, non-synchronous prescribing. There's lots of things going on, asynchronous prescribing, I should say. There's lots of things that are going on that ministers and government will place on the ARPA and the board to do without any extra funding. So, of course, then the profession has to pay for it. And so, you know, ultimately, we exist because patients come and see us and the community sees us. And there is a certain expectation to maintaining the profession's integrity and reputation. The reason I think, and many of us get into medicine, is because we think it's an illustrious career, and it's very admired by the community. And I think that level of trust that the community has and the public has in medicine needs to be somewhat preserved. If it wasn't, then you would see patients not coming to see us, right? And so that's everyone's responsibility to make sure that the public trust is there and that people trust their GPs and their specialists so that they can go to them for advice. And if we're not addressing some of these concerns like cosmetic surgery, medicinal cannabis prescribing, and, you know, other kind of, you know, high risk areas, then the trust goes down. And we've seen it go down from lots of different areas when there's four corners reports around doctors doing this, and, you know, Medicare rorts and all these other things that, you know, really pull our whole profession down and make us all look like money-grabbing doctors when a lot of us are really not that. And so it's all about, you know, how we preserve our profession. And unfortunately, that does cost money when all these new things come out. But you're right. I think if you're an everyday doctor that's doing the right thing, it does feel like you're being penalized. But unfortunately, you know, there's no way of us charging, you know, the bad doctor more and the good doctor less, if that makes sense, and the equity around that.
It seems odd to me that this isn't government funded. I don't know why it seems odd to me, but that feels odd. Is that the same in other countries? Like, do doctors fund their own regulatory boards?
I think so. It comes with the...
Do you know? I don't know.
I think so. I'm not really sure what the other states do. The GMC, I think, in the UK is probably the most similar to us. I think it comes with the cost of self-regulation. So I mean self-regulation, meaning the medical profession is regulating ourselves. If we were to get government funding, then the government will be the regulator. And I don't know if that's the best option, where you have non-medics and government potential bureaucrats who are not medical or potentially from a different specialty regulating doctors. And that could be quite dangerous, I think, in terms of ability to really know and understand what it is to be a medical practitioner when things go wrong.
Now, there's a bit of talk online about scope creep. Is that something you've come across? Is that in your, not in your, I don't mean in your like personal life, I mean more in like your professional roles. Is that something that's come up?
Yeah, definitely. I think it goes to the conversation that we were having before around community need and really what really do patients need. And I think what people do need is, I guess, practitioners who are able to provide the service when they need it and where they need it, if that makes sense. And so that kind of talks about, I guess, at the moment, we know the medical workforce is in a shortage. I think when June and I were going through medical school, we thought we maybe had too many junior doctors and we were all worried about getting intern places. But now we definitely know that there are intern places everywhere, and in Queensland in particular, and I don't know, other jurisdictions or states are the same. We've had lots of hospitals, particularly regionally, have undersubscribed from internship, which is kind of scary to say. And then you get the whole middle grade group, which is, your pre-vocational unaccredited registrars and the difficulties around that space, and, the shortages of medical registrars who are running some of these hospitals or whatever registrars, in whatever specialty. So then you think about there's a medical workforce shortage. It takes 10 years often to make another specialist or, even to get a med reg these days. And so what other groups could be helping out in this space? And that's when you talk about scope and I guess scope of other practitioners, whether that be nurse practitioners. There was discussions, as you probably have heard of, about physician assistants, which are quite prominent in the US and the UK, but we do still have physician assistants in Australia, just in small numbers. I think the message here is that I try and avoid the turf war, which is the whole thing that doctors can only do this and nurses can only do this and pharmacists can only do this, because I think it just puts off everybody, really, and no one wants to listen when everyone's just trying to defend their own turf. I think what we really need to be talking about is true interprofessional collaboration and how we work together as the different health practitioner groups to provide the best care possible. Like, I think all of us have gone through medical school and junior doctor training and internship and things like that, and really we don't really understand the roles of other practitioners that well, and neither do they us, because we don't work or educate with them. We don't, I was talking to a nurse the other day in our ward, and they were doing the exact same education in the next room from the junior doctors who were doing the same education on the same topic. And I just kind of thought, well, wouldn't it be nice if we just combine education and then figure out what our roles are within each other's scopes and how we can, work together to be the best. And it goes to the whole thing around, when we were very junior, I think June, there was this whole debate around whether nursing staff on the wards should be doing IV cannulas. And I thought it was the best thing ever that on my night shift, the nurse could do the cannula and I didn't have to do 10 different cannulas on 10 different wards. And that was very controversial, that a nurse would be now, doing a cannula, 5 years before our internship. And now most wards will have, nursing staff that can do a cannula, and so that you don't need to call the night ward call. So I think it's about allowing different roles to have a more fuller scope rather than this conversation around top of scope, which is about an interesting thing. Because it also means that, now that I'm a consultant, I know I can do junior roles, but you don't really see consultants doing junior roles as well. And so are they really doing their full scope of practice? I think probably we're going to see more consultants doing night shifts and things like that as a gen med consultant or even AD consultant, because we need those people to be able to do full scope of work rather than just what we think a consultant should do, what we think a registrar should do, and what is an intern job and not an intern job. And so it's a broader conversation within our profession of medicine, but also across the different professions and how we work together to ensure we've still got the patient still there. And the patient's ultimately what we're all here for.
Something you're a very passionate person. I love the passion. Is there something else you're passionate about? Doesn't even have to be work related. What do you do?
Well, I don't have any hobbies. This is my problem. My partner also, he's very good to me, and he allows me to do all these things. He's not a doctor, which is great. So I do have to pay credit to him. But you're right. It goes to this whole topic around, I think we mentioned it before, around medical leaders and how we look after their well-being. Of course, I think, we should be looking after the well-being of all doctors, junior doctors, medical students, senior doctors. But we often forget that some of these people are the medical leaders. Like, I've seen my chief medical officer work extremely crazy hours, emailing at 2:00 in the morning and on call all night, and they're coming on doing these things. And I see lots of junior doctors doing that. And we really need to talk about, I guess, how we're preserving the medical profession from a well-being and burnout position. And I think there's a lot of room to go there, because I think a lot of us are just leaving medicine. Like, I think there are lots of people who are moving into non-directly clinical roles because they're burnt out, you know what I mean? And they are seeing more, innovative careers. Like, they can make just as much money, if not more. And why struggle through medicine if, it's not as rewarding as you thought it was going to be? And I think a lot of us are doing that. So I think the profession really needs to look inside and see, that this is a big issue, and that's been a big issue for a while, junior doctor wellbeing and, doctor wellbeing in general. And I think we need to do more to really make sure that our careers are rewarding, and that we do have variety in our careers, and that we can be supported in that, so that we do stay in medicine. And so ultimately that the population does have enough doctors to be able to practice across Australia. But challenging. There's no quick fixes, but I think there are lots of little things that need to change around how we train, the barriers to examinations, how that goes, and what we ask people to do in terms of sacrificing their professional and personal lives for a whole year to get through this one exam that makes or breaks you. And I think, is there better ways to train? And I think there are growing models around that. But I think we have a long way to go around that. I also think the hierarchy in medicine is getting better. I think particularly with our generation, like I don't get any junior doctor or medical student to call me Dr. Abdeen. Like I just think it's strange. And, this hierarchy of, you can just have my phone number and call me anytime. And there is a lot less hierarchy than I think even June and I were in med school. And we're seeing lots of junior consultants now come up through the sphere, and they're changing that culture of hierarchy, which is quite challenging, I think, in the bad days of, I did it this way, so you have to do it this way. And I think also people are more empowered these days to talk about these things, to talk about, things like their sexuality and other things that, were challenging back when we were in med school, and how all these types of things make, a diverse medical profession. And we know, for First Nations trainees, there's lots of issues around bullying, harassment and racism. That's another big issue we're missing out on. International medical graduates, dare I say, is another hot topic at the moment, and how we're supporting them to have fulfilling careers within the Australian context.
Yeah.
And so, we really need to be doing a lot more. Yeah, we need to be doing a lot more in that space to support international medical graduates, because they're vulnerable. They've often come from countries that are, away from a country with minimal support. They've come to a place where maybe they don't have family. It's a new context of their professional and personal lives. A lot of their jobs are linked to their visas. So it becomes really, really challenging for them to raise issues, particularly around issues around bullying, harassment and racism, because they don't want to rock the boat. They don't want to fail their terms. And that's where that hierarchy piece comes in, because they do feel very vulnerable, because they feel it is a very hierarchical system that looks after them. And, if you need somebody to tick your box off, you're going to be nice and just keep sitting there and just doing what you're being told, rather than challenging anybody. Because, particularly if it's related to a visa, you don't want to be going back unnecessarily and, failing, what I'm sure there's lots of expectations of people who come across to practice in Australia. So big issues in that space.
A very similar sentiment occurs. I think a similar sentiment occurs with unaccredited registrars as well. What else was I going to say? You said something. Do you think, and I know it's been an hour, so we should wrap up, but do you think medical students graduating now have better career prospects than what they did 15 years ago?
That's an interesting question. I think it's how you define better is.
Because can I tell you?
Yes, please.
Can I tell you my? Yeah. So, from what I've observed, I think work life is better in terms of overall working hours and on-call mandates and the reduced hierarchy structure. That's, people are a lot more approachable. Those things have improved immensely. Of course, things could always be better. But on the flip side, I've also observed that I think training selection is getting more challenging. We have this large pool of unaccrediteds who tend to all be very excellent candidates with only finite positions. And so from that perspective, prospects seem worse. What do you think? For med students graduating now, are things overall better? Are things overall worse? Is it somewhere in the middle?
I think I'm going to go with the middle answer, somewhat safe answer, only because I think there that you're right. There is a lot of competition, and I think there's much more competition than there was 50 years ago. Like I've heard of consultants who said, "Oh, I tried oncology as an advanced trainee." This is, which means now there's selection processes in place, but they just tried oncology and then they did some renal and then they decided to end up doing ICU, which is completely different specialty pathways, right? Like you'd never see these people crossing pathways like that anymore. Although there is a big push to now support that, because I think that's part of the flexibility in being able to move from one college to the other and have recognition of prior learning rather than having to go all the way from the start. And so that's an interesting concept in itself. But you're right, the competition is much higher, and which is difficult. Whilst the competition is much higher, I still think that there is more training positions, though, than there ever before. So, for example, rheumatology had one every 2 years, I believe, in Queensland 10 years ago. And now we have 7 now. And so there are much more positions. Your chances of getting in are increasing because we are actively focused on trying to increase the number of rheumatologists in Australia because we have a shortage. Saying that, though, I think you need to be smart as a medical student and an early pre-vocational doctor about what career pathway you want to choose. And choosing a specialty that's highly oversubscribed from a consultant perspective is challenging because you may not get a consultant job as well. So you need to think about the long game is my advice with these type of things. Specialties such as emergency medicine and cardiology and things like that are quite difficult to get city jobs now. And so you need to think about where you want to work in the future. And if that's not, if you don't want to work out regionally or rurally, then this might not be the pathway for you. Although if you do, then that's fantastic because those people will get another specialist in that space. There is more information than there is when we went through med school, I think, June, in terms of, which specialties are oversubscribed and which are not. So you just need to look for that. A lot of the states have now, so Queensland has a site called Medinav. I believe New South Wales has their own site in terms of workforce modelling and tells you the balance of how likely you're going to get into a specialty, how many average attempts you need to do to get onto the program. So there's lots more information out there, which is, good. But I do think that there are challenges, as you've mentioned, Hash, like in terms of, getting into this position that you want, where you want it, and getting a full-time public job. You might not get that full-time public job as soon as you finish your fellowship. But, you might find multiple FTEs and do some private and public, which I think suits a lot of people anyway. So I think my advice is, that it is going to be challenging. It was challenging to get into med school. I think that will be another interesting thing. Is it more challenging to get into med school now than it was, when we went through med school? I would probably think so, that it's more competition. But I think once you're in medicine, you've got to realize that I think you've got a lifelong career. You'll always have a job no matter what you do. So, if you decide to be a generalist, in particular, if you want to be a general practitioner or a general physician or a general surgeon, you'll always have a job no matter where you go, and there'll always be a need for that. So it's about realizing which careers are going to give you the job prospects. And medicine's one of those interesting careers where, in any other job, if you look at the boss, which is the consultant, it's not like every intern in any other position, like a law or anything else, would become a boss. There's this, escalator where you go from internship to consultant. And I think though you'll probably see a lot more people become senior registrars, and they'll be in those positions for a bit longer before becoming consultants. And that's just going to be the new thing, I think, eventually, once we get that bottleneck at the top. But I do think it's a concern about the unaccredited registrar space and what we're doing to support that space in this whole situation, because they are vulnerable, as you've mentioned, Hash.
Yeah, I'm sorry. My webcam's busted. I'm sorry. Anyway, well, thank you, Hash, for joining us. You've actually shed a lot of light on committees and organizations that I only know about a name, and I'm like, oh yeah, they do something, and they do something. And you've really painted in a way that, I don't know, I feel like it reduces pessimism, because there's a lot of us versus them, like doctors versus the administrators. So breaking that down, I don't know, I really appreciate it. But hopefully we can do another session at some point.
Perfect. Thanks for having me.
Do you want junior doctors to look you up anywhere or vote for you anywhere?
Oh, no, nothing to vote for, nothing to look me up. I'm not really a social media person at all, so you won't be able to see me anywhere. I try and keep a low profile as much as possible, although you found out a lot about me already, which is concerning, but also fun.
Yeah, no, it's been a great discussion. I think, definitely we need probably more episodes with Hash. But yeah, thanks for coming in, Hash. That's been very insightful today. And yeah, you're welcome to come in anytime for another episode as well. Yeah.